Good morning, everyone. We're happy to treat live here at Mount Sinai, Room 1. My name's Rob Lookstein. To my right is one of our stellar fellows, Raj Rao. I just want, before we start introducing the case, I just want to give just a more broad introduction. I want to obviously thank all of our support teams, the nurses and the techs, and our colleagues in anesthesia that allow us to put on this educational content every month. We have a great case. We're doing it a little bit differently. This is something that sort of came up, and I thought it would be a good opportunity to try and evaluate what I would consider to be new technology. And so we have a really interesting case that we're going to share with you today, and hopefully we'll make it, really educational and go through a lot of teaching points about it. We have a PowerPoint deck that Raj has put together, and if we could start that, and if we could just get confirmation that that's on the screen. Okay, so Raj, go away. Let's go. Let's talk about the case that we have here today.
Sure. Next slide. So this is a 75-year-old male with a history of AFib, not on anticoagulation, diabetes, hypertension, hyperlipidemia, CVA, and subdural hemorrhage from 2022. The patient has endorsed worsening pain in both of his feet, which over the past 1 year has developed into rest pain, more predominant on his left lower extremity than his right. Medication-wise, he's on aspirin, statin, metoprolol, gabapentin, and amlodipine. He is a prior smoker with a 7.5 pack year history, and he lives a sedentary lifestyle, partially due to the lower extremity rest pain. Um, Physical exam is remarkable for non-palpable DP and PT bilaterally. He does not have any wounds or ulceration in either of his lower extremities and no signs of gangrene. Labs are overall unremarkable. Next slide. You can play the video. So if we pay attention to the left here, we can see on the left side, there's no significant iliac disease. He does have some degree of CFA disease, and there is a proximal SFA stent here, which the patient does not recall having being placed. Distally, there is some SFA and popliteal disease as well. And on the next slide, we'll show the distal runoff. Next slide. So this is the distal runoff, which demonstrates multifocal. Right now it's still in the SFA, but it demonstrates multifocal occlusive disease below the knee involving all three tibial arteries, particularly the tibioperoneal trunk. On the right, we have a 3D recon demonstrating the same degree of multifocal occlusive disease. Next slide. So in summary, this is a 75-year-old prior smoker with a history of AFib, not on anticoagulation, hypertension, hyperlipidemia, diabetes, CVA, and bilateral ischemic rest pain of his feet, more predominant on his left, found to have multifocal disease above the knee and occlusive disease below the knee in his left lower extremity. The plan for today is a diagnostic angiogram and revascularization of his left lower extremity.
That's great. Thanks, Raj. So just to get everybody up to speed, we've placed a 6 French up and over sheath from the right common femoral artery into the left common femoral artery. We didn't do a diagnostic aortopelvic angiogram because the CAT scan essentially cleared it. I don't think there's value to it. But in real time right now, we're going to do a diagnostic left lower extremity angiogram. And you all watching in will see the findings literally as I'm seeing the findings. And so we'll sort of take a look at this together. And at least so far, the proximal SFA popliteal segment looks normal, which is obviously encouraging. And we're going to just march down a little bit and try and continue to make progress here. And Raj, if you could just hit a DSA run for me, please.
Mm-hmm.
Oops, sorry, hold on, let's refocus. Perfect, much better. Go ahead, thank you. Again, popliteal artery looks relatively unremarkable. And we're gonna, again, focus down below. Do another diagnostic angiogram here. And I'm gonna put the knee joint at the top of the screen. And let's go again. And now we're getting into the meat of this case, all right? So just to summarize so far, and as we cycle through this, I think you'll see that there's pretty high-grade stenosis of the mid portion of the tibial peroneal trunk. Posterior tibial artery is obliterated, and we have what's starting to look like multifocal stenotic disease in the anterior tibial artery. I'm going to focus a little bit lower. Raj, can you just hand the pedal over to me, please?
Sure.
And obviously, I think this is going to suggest that this patient probably has, really no inline runoff down to his foot. This is, closer to an AP angiogram. We'll see what this shows. We might do a formal lateral foot in a minute, but I sort of want to get a sense of what this is looking like. And you're seeing what looks like AT and perineal going down. So we're going to do a full lateral foot here. So I'm going to oblique the tube so we can really splay out these infrapopliteal vessels and get a better sense of what's happening. This looks like a pretty good lateral. Oh, I think we have a special guest coming in. And so, Joji, if you're online and you want to comment on what you're seeing so far, I'm going to shoot the lateral foot. If you can hear me, just confirm that you're online.
Yes, I'm online. Yeah, I can see it. Yeah, so
Oh,
looks
fabulous. So just let me just formally introduce you. I think we were able to get a special guest who's a very dear friend of Mount Sinai IR. So it's an absolute pleasure to have him with us right now. Joji Vaticancheri, who I think is well known certainly within the interventional radiology community, not only in the United States but around the world, but also a preeminent vascular educator. And so, Joji, it's an absolute honor to have you joining us. I know this was last minute, and I really appreciate your input here. So you've seen the runoff just like I've seen it. If we could go back to the previous two runs, because I think that's where the action is. So what are you thinking about this case so far? Obviously, the patient has, fairly compromised runoff. You see there's only two vessels that are going below the ankle. It looks to me like there's perineal continuation of the PT, and then you have a compromised AT. What are you thinking about this so far?
yeah, no, I agree. So the guy with kind of Rutherford 4, I would probably focus on the AT and then probably the TP trunk would be my top two kind of efforts. The AT seems to go into the plantar loop and kind of retrograde, filling some of that PT territory. So that would be my strategy.
So we
And
could do, I mean, we could do a lot here, and obviously there's, it's not a black and white case. I want to, just in your practice, how would you manage this? And I'll just give you sort of the picture that I'm thinking of here when I think of, how I'm approaching this. I think this is the so-called money shot, right? So what would you do? Would you do one vessel? Would you do two vessels? Would you do three vessels? How would you
yeah,
approach this?
I'd probably leave the PT occlusion alone, and I'd target the AT and see if I can get pretty robust flow into that plantar loop, and then plus or minus the TP trunk, because like you said, the perineal is supplying the foot as well. So that would be my two kind of algorithms.
Okay,
And then
so I'm just gonna, yeah, go ahead, please keep
no,
going.
and then depending on how calcified, use some type of plaque modification, and that AT looks, it may or may not be calcified. The CT is usually helpful to kind of guide me as to how much calcium, and in those
Yep.
situations, I'll tend to use some lithoplasty or some type of calcium modification now.
That's great. So how about this? I'm going to try to wire the anterior tibial artery and see if I can do that. And then we'll prep that and see if that needs, either one or more scaffolds after we've prepped it. And then we can try to tackle maybe the TP trunk on the way out at the end. Does that sound like a good plan?
Yeah, and I think that's very
Okay.
reasonable.
All right, so let's get this wire loaded up. This is can I have a whisper wire actually, please? Right. This is not. All right. So I'm just going to get rid of this. Thank you. So let's talk about crossing wires. What wire do you like to use to cross something like this below the knee? There might be a very short segment CTO there in the mid portion of the anterior tibial artery.
Yeah, so that's exactly right. So I've used kind of my cop two now, kind of the 014 glide wire advantage, kind of a 100-foot tip that I can kind of spin around. And sometimes the command 014 wires are kind of my top two. And then if it's really tight or like
Load in the
tortuous, then
back
I'll
end of the
even
wire
use
into the support
like
catheter.
a fathom wire that I can really manipulate well down there to get through the track, and then a microcatheter or a low profile balloon, like a 2 millimeter balloon that I'll use to as my crossing catheter.
So so you're using basically non-coronary wires, it sounds like,
Yeah,
preferentially.
yeah.
Yeah, I've almost gone completely over to using coronary wires, and it's some stuff I've just over the years I've gone accustomed to sort of speaking to my friends that work in the cath lab and sort of seeing how they tackle. Pull back, please, slightly, and we're just going to break the seal here. I'm using an 018 support catheter, and let's switch it down for the front end now. And let's put a slight curve on this just so we can catheterize the anterior tibial artery. This is great. So I'm just going to put a little curve so that we're going to preferentially go into the AT. And then let's load this up.
And then what's your anticoagulation regimen right now?
So we literally just only gave 5,000 of heparin a little while ago. We're going to check ACTs intermittently. And I think for me, the sort of good checkpoint is when we've crossed. So I'm hoping that once we've crossed this successfully, that we're going to be able to obviously identify whether we want to use IVUS to size this, whether we want to use some other technology, and then how do we choose what kind of treatment strategy we're going to use to be able to get this done. So I'm just, again, chasing myself up to the SFA. You see my wire there. And we're just going to advance this all the way down. And as you might imagine, Raj, can you pin down the wire for me? Thank you so much. And we're just going to go right down to P3 with our support catheter. I'm going to mag up slightly so I can see what I'm doing. Excellent. And let's let go of the wire now. Let it flow down. Great. So I'm going to see now if this loop will allow me to catheterize the AT. And more often than not, I find this is a little bit of luck. But we'll see. There you go.
There you go.
All right.
Nice, very nice.
All right. And clearly I'm off the path, right? So that is not the true lumen of the AT, but allows me now to be able to focus myself and get myself reoriented so I can wire it. And I'm just going to mag up so everybody can see what we're doing here. So obviously that was not in the AT, but I'm in the horizontal portion of the AT. And again, that's where I think I went off the trails. And now that looks like it's much better here. All right, and let's follow me down. And again, I'm off the rails, so we have to be very cognizant of that. There's no reality where the AET looks like that. And so I'm just very gently guiding it. This looks like it's going, again,
Something
not
there.
easily. So I want to readjust it. Something going on, popped right through.
Oh, nice.
And I'm going down. And again, no contrast because I know what the course is going to be, following it with a support catheter. And this looks like it's just going to go straight down into the DP, which is nice. I'm going to orient the II just so that we can confirm that I'm in the DP, but I think this is pretty good confirmation. And then, do we have a grand slam on the table? There's my support catheter. And I'm a very, very big believer about what I'm about to do. I'm going to get rid of this whisper because I don't need it right now. But I always confirm 100% once I've crossed that way that I am where I think I am. And so first and foremost, I'm able to aspirate blood, which is a good sign, obviously. But you never want to take that for granted. And so just fluoroscopically, I think you'll see that was saline, so that wasn't helpful. Can I have a little bit of contrast, please?
And I think that's a critical step to always confirm where your distal axis is.
There's no question. We want to be absolutely sure, especially before we start advancing balloons or some other, augmental material. You saw
Yeah.
that, right? So that was 100% in the dorsalis pedis artery. So now we're going to put, that was a crossing wire. That was a whisper wire, which is a coronary hydrophilic crossing wire, and it worked very well. And I was able to torque it just with my hands, which, worked beautifully. And then the Grand Slam is a coronary support wire with a
That's a
floppy
great one.
tip. It is not designed to cross. And, again, it goes right down the DP very, very well. And what I think I'm going to do here, just because that was a little bit easy, is I'd love to set up 014 IVUS. Can we do that, please? And maybe we can watch the wire. Let's just get this out. Yep. If we can do 014 IVUS and then really map out what the diameters are here, and this is going to be critical because if we decide to go with a scaffold therapy here, I think it's going to be really useful to understand what the reference diameter that we're using is. So just to summarize, we just crossed the anterior tibial artery. We have a good support wire in the dorsalis pedis. I'm going to demag now because we're going to do intravascular ultrasound. And we're going to talk about, sort of how we're going to prep this vessel so we can get the greatest amount of luminal gain. And if I had to guess, we're probably going to end up prepping this with either a 2.5 or a 3.0 balloon, maybe even bigger. And then on the way out, maybe we'll touch up that TP trunk. I think that intravascular lithoplasty, to your point, is probably going to be pretty beneficial for that TP trunk. And I think you can see here on the fluoroscopy, I'll just zoom up,
Okay. Yeah.
that there's some calcium there hidden. I think it's, a little dense. If I could bump up the juice a little bit here, you see that calcium in the TP trunk. So it's pretty dense. And I think I'm going to probably modify that, plus minus a scaffold there. So let's get the IVUS set up and ready to go. And again, Joji, you and I will be looking at this for the first time. So we'll make a decision about how we want to deal with this based on what we're seeing. Are we plugged in?
Just plug it in.
Okay.
Yeah, and I think the IVUS is really nice to just get true luminal diameters and also interluminal kind of calcific plaque and see what that's doing.
I think that now we're in the era of scaffolds below the knee. I think it's absolutely imperative that you use intravascular ultrasound. There's certain people I think that use optical coherence tomography, but I think you really need to be thinking about using intravascular imaging when you're doing these cases, especially BTK cases. I think if you're going to, provide, bailout therapy in the form of a scaffold, that you have to have it properly sized. I think that's absolutely critical. And so we're going down. Can we adjust the image, please? I'd like the image to be, I'm going to say 10 millimeters in diameter. Can we go back to live? Thank you. Yeah, let's adjust the image, bring the diameter down to 10. Oh, we are at 10. Bring it down to 8, please. Great. Okay, so we're going to keep on going down.
See the calcium there.
You see a lot of it, right? I'm going to do a pullback in a second. All right, so we are down. We are, I think, all the way down into the distal AT.
Wow.
And yeah, so this, you see all the calcium there in the wall, right? Can we start recording, please? So we're literally at the AT as it's going to enter through the interosseous membrane. Let's record, thank you. And I'm just pulling back. And you see, a mild stenosis there, maybe, some severe calcification there. Again, a lot of calcium here, a lot of calcium. Here's some plaque. And you can see the diameter of the anterior tibia is changing dramatically, right? And just example there, that looks to me like it's closer to 3. The lumen is, far less than that. This is a very tight stenosis there. You see no lumen at all.
Yeah.
Right? And, clearly a bigger lumen up here. And, again, this area here, if we look at that, that's a much larger lumen. A lot of soft plaque in that. And again, you might look at the angiogram and say you need, a 2 millimeter balloon, but it's so obvious to me on this IVUS. Here's a great example. This is clearly a 3 millimeter lumen. And again, we're in the vertical portion of the AT, but we're really sizing up like what we're going to use here. Look at how much plaque is here in this area, and how much luminal gain there's a potential here. So from at least my point of view, and we can go back manually and do this. Here's another great example. This is proximal AT. Can we freeze that? I just want to let's measure that all the way at the end there. The last image that we took, let's bring it all the way down to the end. Wait a second. I'm going to check an ACT in a minute. Let's measure the diameter there, please.
Which part of the AT was this?
This is the proximal, I think more by the white line where the calcium is, that's much better. Yeah, so that's a 4 there. All right. And again, that's so informative. If you use a 2.5 millimeter balloon here, you're barely going to get anything done. Let's go back to live. Great. And now and record again, please. Excellent. And so again, we're going into this. Now we're heading into the vertical portion. Sorry, the horizontal portion of the AT. All right. And again, a lot of calcium here, right? You see tons and tons of calcium. And, really some very interesting stuff. So let's freeze it there and measure that diameter, please. Four and a half. Wow. Okay. All right. I think we're done with IVUS for now. This was really helpful for me. I don't think we're going to need to go into the pop. You can watch it while I'm watching it, but there's nothing significant that I'm seeing here that's going to make me go into the FemPop segment. I think it's pretty wide open. All right. So let's stop with the IVUS.
Yeah, the stent looked pretty good too from what I saw, the quick run by.
Yep, I agree with you. I think the stent looks fine. All right. So I'm going to take this out. And at least first, I'm going to ask for a 3.0 by 220 balloon. And again, based on these sizes, I think we might even be able to use a new IVL platform for the proximal portion of the AT. But I do want to get a little bit of luminal gain before we do that. Do we have a 3.0 220 or a 3.0 150?
Yeah, I tend to often vessel prep for the lithoplasty because sometimes it's hard to track depending on the taper.
Well, we have a new tech that we've been using in our lab that I'm looking forward to showing to you. So we're getting in a 3.0 150 balloon, and we're going to dilate the AT in 2 segments. In the meantime, can I have an ACT syringe, please?
Now, this patient, it sounds like had much subdurals in the past. What's your kind of algorithm, say, after this interventions for antiplatelet or even anticoagulant?
Yeah, so that's a great question. So we're definitely going to put him on clopidogrel. And I think that, it's always risk reward. We obviously, had him evaluated by our neurosurgical colleagues, and they felt because he's relatively distant from the incident event, the risk is low. And just as a concept, they did not recommend triple therapy, which I think would be too aggressive, but I think dual therapy is probably worth it. And again, this is in the setting of somebody with pretty severe rest pain, who's really miserable, can't sleep at night, and he just, couldn't get anybody to engage with him. And I obviously feel very, very bad for him. He's very symptomatic. And so we're trying to do our best to give him durable relief. And then, the question comes up, which I think is a reasonable question, Joji, and I'm really interested to hear your perspective on this, is, in this setting when this patient basically has 2 vessel runoff, there's a perineal, which looks like it continues into the PT and the anterior tibial for just rest pain without tissue loss. Do you do a single vessel revascularization or a 2 vessel vascularization? And And the question comes up is, is a two vessel revascularization going to be more durable and maybe avoid a clinically driven revascularization for this patient who, is really, really miserable right now and has terrible quality of life. And, obviously, I think if you asked him, he would prefer not to have to go through this ever again and not to be symptomatic.
Yeah, I mean, that's a really good
So
question.
I'm just curious about what your thoughts are and how you balance it and how you get informed consent for these cases, et cetera.
Yeah, I mean, definitely I would talk to them about the kind of the rest pain CLI component. Most of the time, I'll try just to get out with if I get good robust flow in the AT and see how he does. But if he's kind of really recalcitrant or doesn't want to come back, I think the TP trunk you'll have pretty good patency, especially with kind of drug-eluting technology that we have now available. So I think the TP trunk is relatively low risk, high reward. So I wouldn't be
Up to
against doing
14.
that. But typically, I'll
All
just go
right. So this
AT
is the.
on segment.
Sorry. Go ahead. What were you saying?
Sorry, typically I'll go, revast at AT and see if I get pretty robust
Yeah.
flow, and I'll leave it at that. But I don't think
14.
it's unreasonable with modern day tech to go after that TP trunk with the
Let's take it
drug-eluting
down for a
scaffold.
second. So I just want to prep this balloon a little bit better because it was a little bit hard to see what we were doing. And let's go again.
Some more contrast in here.
And go ahead. Much better.
Now,
Okay.
14.
Excellent. All right. You see the balloon. We're getting really good luminal gain here. There's nothing recalcitrant that I would say. And I'm just changing the orientation so you can see it. Obviously, these are all a little bit challenging when you're getting so much overlap with the bones, okay? But I think we have really good luminal gain here. We're gonna leave this up for about 60 seconds. And then we will move it up. I don't think I need to go deep into the ankle. I don't think it was affected that severely. And then we'll do another angiogram, but I think we're gonna prep the origin of the AT. And if we could start to prep a 3.5 lithoplasty balloon, that would be great.
What lengths do you have of your new platform as far as?
So I'm gonna share it with you in just a second, but the one that we're gonna demonstrate today is a 60 millimeter length. It's a relatively new technology, and we've been lucky enough to evaluate it as part of the limited market release. But I think it's a very disruptive technology. It's really transformative. And again, I'm looking forward to a good conversation about it. Let's take this up. And here we are bridging all the way into P3 almost. So again, same inflation. And
And
this looks
using a
great.
14.
Yeah,
semi-compliant balloon
excellent.
right now?
Yeah, this is a semi-compliant balloon. The specific balloon is the Coyote balloon. We preferentially use the rapid exchange platforms, which are really really excellent for this kind of work. I'm a big believer in rapid exchange. That's all the coronary equipment. But these balloons are semi-compliant, and we're taking this up right now to about 3.2 millimeters just to sort of prep it. And then again, I think we'll do the proximal portion of the AT with a 3.5 lithoplasty balloon in just a few moments. But we want to make sure that we've got good luminal gain here. We'll show you what that looks like in just a minute, obviously. But Raj, if you want to get that prepped up, that would be great. So we're not wasting time. So Joji, when I think about IVL, it's clearly becoming something that we're incorporating more and more into our practice. In your practice, are you using it, all the time, sometimes, never?
Uh,
Are
a
you
lot of
not
the time.
enamored with it? How do you think about it?
So, I used to do more orbital atherectomy, and now that's gone way down. I rarely use it unless I can't cross. And so I'll kind of vessel prep it with a low profile balloon. just so I can get the shock or the kind of that lithoplasty technology down. But I use it quite a bit in the FemPop and tibial and even the iliacs now with the larger diameter ones they have. So I've been
So would you
using
say it's like
it.
50% of your cases, more?
Maybe more than 50%, because we're seeing a lot of kind of dialysis and
Saline.
patients, so they're
50-50.
pretty calcified.
So we just got the ACT back. It's 255, and again,
Okay,
this is a great conversation. Do you think we should boost it a little bit higher?
I'm pretty
How
happy
do you
with
like
that.
to do your below knee? I'm gonna ask for
250
another
above.
1,000 of heparin just to sort of keep it maintained, so I don't need to worry about it.
Yeah,
Um,
I tend to do 100 units per kg
and
now just to get them therapeutic, and then I'll check the ACT in 5 to 10 minutes, and then yeah, 250 or above, I'm pretty happy. But
so
I'm
that
not.
yeah, this patient's got now a total of 6,000, and if we can keep it between 250 and 300, I'm going to be pretty happy. So I'm just going to do a run, and this is just for educational purposes what we were able to get after POBA.
It's
And
pretty
it's
nice.
not bad. The AT looks better, right?
Yeah,
All right.
pretty nice.
But we obviously
Yeah.
saw in the IVIS that there's really
Saline.
significant dense calcium, especially in the proximal portions of the AT. So I want to optimize that. And if you really, I think, interrogate the angiogram, you're going to see that there's a lot of lucencies. And I think that reflects calcium in the anterior posterior plane. So I think
Mhm.
that we're gonna IVL this and see what we get at. We might IVIS it afterwards, and then we might call it a day in terms of the recording, and either say that this is optimized or do the tibial perineal trunk off camera, but we'll see. But that's one of the reasons that I think that IVIS is so helpful here, because we know that this AT, even though angiographically it looks great, we know on IVIS that there's really severe luminal compromise. So the platform that we're going to share with you is the second FDA approved peripheral IVL platform. It's currently being commercialized and distributed by Boston Scientific. It's called Seismic, and I'll go over this in a little bit once we get it down into the patient. Most conspicuously, this is not a electrical based IVL platform. It's a laser based IVL platform. And so the IVL is really activated by laser energy being transmitted into the balloon once it's inflated to create the pulsations. And then there's a couple of very nice features that I'll go into in just a minute. And you'll see there's some very conspicuous radiopaque markers that we're going to notice in just a few moments as we get this up.
And
And
one of
you're
the
seeing the
challenges.
markers there.
Oh yeah, yeah,
All
very
right, and
well.
this tracked obviously very, very well, and so there's no imitation set. So I'm going to mag up because I think this is
Are
just
those all
worth
emitters?
reviewing this. These are the emitters, and of note, you can see that the emitters have a different orientation, and that is intentional, that is by design. And so the emitters, there are, for example, the most caudal emitter almost looks like there's two parallel tracks, and those will emit in the lateral plane. So they will literally emit from the patient's left side to the patient's right side. The emitter, which is immediately proximal to that, there's the so-called fourth emitter, that is superimposed, and that's going to emit in the anterior posterior plane. And then conspicuously, if you really conceptualize that, all the emitters are organized along a helix. And this is a unique feature, unique feature of this technology as compared to the first generation technology, where you start to approach something that looks like directional IVL. And so if you have something that's eccentric and somewhat recalcitrant, you can focus one or another of the emitters directly into that lesion to be able to focus all of the energy. So that's the first thing. The second thing, and I don't know that you can see the actual console here, but the console, is the console able to flip around, or we're not able to do that? That's great. So can we focus on that for just a second? That's wonderful. So just 2 seconds on this. So one thing is that you'll see on the left, there is a a scale which shows you the pressure that is being
Mhm.
administered into the balloon. And we'll take up the balloon to 4 atmospheres now. And we'll watch
And,
it under fluoroscopy. Go all the way up
and
to
what's your
4.
sizing?
So this is a 3.5 millimeter balloon. All right, so I want to prep this a little bit more just so we don't have any air in it. So we get a little bit more luminal gain. Because I really think that's an important feature of this to be able to optimize it.
Yeah, and that's always a challenge on these is to get all the air out. Um, and so, can you do? How have you, with your experience, what have you seen with eccentric calcium?
Let's try this again. So we've done about a dozen of these cases. This is looking much better. Keep on going all the way up to 14. Right. There's a little bit of air in there, but for the purposes of this, I'm going to show it. So you can see on the screen, we're at 4.6 atmospheres. The handle, which is in my hand, is now activated because it senses that you're at an atmosphere where you have wall apposition. And then we're going to, again, activate it, and you're seeing that it is deploying the charges. You're seeing the bubbles activating. And right now, all 5 emitters, which is the graphic that's on the bottom of the screen, are being utilized. All right. The other thing that is available, and we'll just demonstrate this for teaching purposes, is that you can actually turn off or turn on one of the emitters. And so just to demonstrate, if we wanted to turn on only the first and the third and the fifth emitters, if we could do that, just to show yep, so that's turned off and that's turned off. And again, we could go the treatment again. And it might be that you have a distal lesion where you only need to focus the IVL energy on a specific location. But that, I think, is one of the benefits of this technology, that you can use it this way. All right. So I want to go back up to 4.5 atmospheres. Yep, that's fine. 5 is fine. And we're going to activate it again. Let's turn on all 5 again because I want to hit the entire lesion. Right. And again, we're activating it, and you can see it working in real time. And what I think we're going to do is we're going to do one level down in just a second. So let's deflate this. And again, if you can pin, I'm going to pin this down. I'm going to move it down and then refocus it. And again, this is a 3.5 millimeter IVL catheter, but I feel really good about the sizing based on the IVUS measurements that we were able to obtain. And so again, let's try to go up again.
And how many like what's the duration of shocks? Like how does that
It's
work?
very, very fast. This is a pretty fast system compared again to I think the first generation system. All right, so like that, let's take, yep, 4.5 atmospheres. And so I'm going to hit it. Now, what'll be interesting to see is how the atmosphere changes as you turn this on. And you're seeing the pressure's dropping a little bit. All right. And that gives you real-time feedback as to whether you're changing the compliance of the vessel. And we've seen that. Let's do one more activation here. You can see that this catheter has 600 charges built into it.
Right.
You could also think of it as 120 charges in each of the emitters. And again, the pressure is still dropping. Raj isn't touching this at all. So we're literally in real time changing the compliance of the vessel to be able to reflect the therapy of the IVL. Let's deflate this now and take this out. I don't think we need to go deeper with this balloon.
So those first and second emitter, was there a little tiny waste there or no?
I didn't appreciate it. But let's do a repeat angiogram after this. And again, we're focusing on the top 10 centimeters or so. And then maybe we'll repeat the IVUS. And then we can tack up whatever we feel like we might need to tack up.
And so when you only have 1 or 2 emitters on, does it generate more power at that site? Or is it the
No,
same?
it's the same amount of of power. But again, if you think about it conceptually, if you want to get 600 charges out of this and you have a focal, 1 centimeter long eccentric thing, you might want to use, one emitter directionally for 120 charges, and then switch to a different emitter and reorient it, and use another 120 charges, et cetera, et cetera, et cetera. And I think that gives you different options. It really sort of takes the technology to a different level in terms of operator control and the
Yeah.
ability to sort of program it to benefit the patient that you might have on the table. All right. So I
Right.
think that proximal part looks really good. All right. And let's get the IVUS back. Now I think you're going to see there in the middle of the screen of the AT, there's something that looks a little bit challenging. You see that area where it's very hazy?
Yeah, I saw that. Yeah.
I think if I had to guess, we're probably going to have to scaffold that. And so I'm going to IVUS it just to confirm that we know the diameter. And again, I think it will probably end up putting in a spree there.
And that was where it was pretty tight to get across, I believe.
I think that was where the CTO was. And again, I think we prepped it well with a 3.0 balloon, but I want to measure it on IVUS and see. I'm not, I wasn't completely sure with sending down a 3.5 IVL catheter. I think it might have been a little bit oversized for that lesion. Let's take this off and prep the wire again. All right. So I always sort of joke when you do these cases, if you could do them underwater, it would really, really help in terms of being able to deliver everything. So if you hold this for a second and give me that, I'll trade you. Perfect. And I'm going to take this, just make sure that this is really, really wet. Okay, now let's try that again. For if somebody could grab a 375 38 Esprit stent, scaffold rather, just so that we're ready. 375 by 38 Esprit.
So I know you've been using a lot of kind of historically, and I tend to use the same as kind of coronary drug-eluting stent platforms. And what's your kind of take on the kind of this new kind of Limus drug-eluting platform that you have now available?
So, I think this is the sort of question that a lot of people are grappling with, which is, when do you use one versus another? You're absolutely right. I have been a very, very big proponent of using, coronary drug-eluting stents below the knee for, 20 years now. And we probably have one of the larger U.S. experiences using that technology. I think from where I'm looking at it right now is if you're going to treat very, very, very long lesions. And again, I think you're seeing here we have a lot of recalcitrant stenoses here, especially here, right? I don't feel comfortable leaving this like this. Can we get a measurement on the vessel there? And I'm very, very lucky in that I have incredible support for IVUS. So that's 3.5, 3.9. So I think a 3.75 taken to 4.0 here is going to be perfect. And again, live again. And let's measure this, please.
And what's your like? How do you vessel prep it differently?
4.6. So this is a great example of this, in that the largest you can take the Esprit is really like 4.2 by oversizing it. And if the vessel, let's look at this. How much does this look like? 3.7. All right. So I think I'm going to put in 2 Esprits right here in the middle of the AT, just to show everybody how to do it. And then we'll do an angiogram, And then I think we're going to try and wrap up here, right?
So before you
And
deploy these, what's your vessel prep? What, like, say you're putting a 375, do you have to pre-dilate a certain amount to get adequate luminal gain?
I think they're on the second to bottom shelf. Yep, the 375/38. Can you open up two of those, please? Fabulous. I'm sorry, Joji. What was the question that you were asking me? I apologize. I was just trying to make sure that
What,
we have the
no, so when
scaffolds.
you're putting a 375 scaffold, what's your kind of pre-dilatation diameters you try to achieve?
Yeah, so minimum is going to be something like 3/4, 3/5, obviously, and I think that if you're trying to get very very close to one to one vessel prep, I think that's a good goal. I think we got to zero point 0.9, some variation on that. Um, and I don't like to over dilate because I get concerned about whether or not you're going to have wall apposition with the implant. So I try to make it so that the device is going to pass, obviously, and then I want to make sure that there's uniform wall apposition to be able to navigate this. So probably first and foremost, I'm going to just prep this to make sure that we really see it blow up very, very well. And again, we're just going to really aspirate all the air out of the system. And these scaffolds are very unique for those of you that haven't had the experience with it. We're going to zoom in on it in just a second. If we can get zoomed in on my hand here, so this is how it comes out of the packaging. If we can see this, that's great. And I'm going to take out the loading stylet first. So that's gone. That's to make sure that the the scaffold doesn't crimp on itself. We obviously don't want to introduce the protective sleeve into the patient. All right. And so this is the actual scaffold. And then I'm just going to, again, flush the tip of this just to make sure that the wire port is well maintained. And then we're going to prep the wire, and then we're going to send this down. And we'll do it under high mag so everybody can see this under fluoroscopy. So Raj, if you could hold this for a second.
Sure.
Thank you. I just want to give another shout out to my superstar senior resident slash fellow Raj Rao for keeping me out of trouble today. It's always very welcome when we have such incredible trainees, and I know Raj has an incredible exciting career ahead of him. But we're very very lucky at Mount Sinai to have such incredible house staff. And Joji, I know you've been a real zealot for resident education over the years. Maybe you could share your thoughts about how you approach resident education and the value of vascular intervention for resident education while we're getting this down.
Yeah, no, very good points. I mean, obviously, I've been lucky enough to work with a lot of your trainees over the years, and you do have an outstanding group that I've had the pleasure of working with. It starts early. It starts at the fourth year of medical school where you're doing the sub-Is and getting exposure. And vascular disease, whether it be cerebrovascular with strokes, coronary artery disease, and PAD, is a very important disease process for all vascular interventional trainees to get comfortable with, whether it be the lipid management, the blood pressure management, the diabetes, and the antiplatelet and anticoagulant management of this population is exceedingly important. So we really recommend you get early exposure to this in your early years, which I know you and Aaron Fishman and the team there have been very progressive in the way you approach integrated training, and the rest of the country is kind of following suit. And so we've been working
Okay.
very closely with the governing boards to kind of make sure that integration is early and often, similar to what you guys are doing. But yeah, big proponent, very important to get this PAD training in your residency wherever you go.
Thank you. Thank you for all that you do all the time. I know I don't thank you enough, but I just really want to thank you for your dedication to this. So here's the scaffold on the screen, and you can see now that we're on slightly higher dose of radiation, how much calcium there is below. I think it jumped a little bit, so I want to get it just down below there. So you're seeing that now. There's a platinum marker, which is on either side, or rather a tantalum marker. It's on either side of the scaffold, and that's the slight dot that's next to the balloons. This is not a radiopaque system, so you really need to go by those markers. And what we're going to do is I'm going to ask Raj to take this up to 18 atmospheres. which is going to correspond to about a 4-1 luminal gain here, and we'll see how it opens up. And there we go.
18.
And that's great. Okay, perfect. Let's leave it up for just 30 seconds. I just want to make sure that it's looking good. So again, that's 18 atmospheres. And again, you're seeing just a little bit more conspicuously the radiopaque markers that are on the balloon now.
Yeah.
I think that's fine. Let's deflate it.
So
And
for your
let's manually deflate this. And then we're going to put in one more right on top of this.
for
Okay.
your antiplatelet regimen, did you kind of load this morning, or are you loading after? What's kind of your algorithm?
He was on single antiplatelet therapy, and I obviously wasn't completely convinced on how we were going to go with this. And so we're going to put him and bolus him on DAPT immediately after this procedure. And it's a great question, but my protocol is, again, I'm watching the radiopaque markers; they're not moving. And so I'm going to take this out, and then we're going to get the second scaffold. And again, you see the platinum markers there. It's a little bit hard to see. I'm on high mag to make sure that everybody understands what they should expect to be looking for. And let's get the second scaffold ready.
Mm-hmm. Second one. Oh, yep.
So my protocol right now, to your point, which is, and it's a great question about how we manage pharmacology for these patients, is I will usually discharge them on dual antiplatelet therapy, and then I'll see them in the office in about a month. And then, we're sort of discussing as a group the issues regarding, the sort of Voyager protocols, Compass protocols. And the fascinating thing, and I'm sure you're aware of this, is that there appears to be a safety signal, at least in the VTE cohort, between sorry, I shouldn't say Eliquis, apixaban and rivaroxaban.
Yeah, the
And
Cobra.
Cobra study, which saw a 50% reduction in the bleeding rate with the use of apixaban preferentially as compared to rivaroxaban. And I think that we're all struggling with how to apply that to our PAD population. We obviously have level 1 evidence for rivaroxaban for PAD in the avoidance of adverse events. Can you just hold this for a second?
Mm-hmm.
Thank you. I just want to wipe down the wire so we don't get stuck. But we're discussing this as a group. I think it's a great conversation about whether or not the bleeding risk is going to translate over to a PAD population, and what does that look like, and what does lower dose have to do with it. But these are the issues that we're trying to resolve right now. But I at least send most of my patients home on dual antiplatelet therapy, and then we decide how to deal with it, in terms of switching them over to a DOAC and single antiplatelet therapy, or just a DOAC afterwards. How are you managing this in your practice?
Yeah, I mean, really good point. I am apixaban has a lot of benefits in the cancer population as well as in the kind of the prolonged high risk provokes, and so pretty good level 1 evidence for a lot of things. But I'm still using kind of rivaroxaban for PAD
Yeah,
patients because of the current data. But I am a fan of apixaban in a lot of the DVT space, cancer and otherwise, and even long term low dose. So I do use a lot of
all right, so
that. Let me ask you a question on
here's
the
the
stent
second
platform.
implant.
When you're deploying these
Yeah.
overlapping stents, what's your algorithm? How much overlap do you have between the two constructs?
So so that's a great question. I think you can see on the screen right now we have about 1 to 2 millimeters of overlap. It's a very small amount of overlap. It's not zero. We don't want them next to each other because we think that might cause irritation. And so I try and get, basically one cell out of it. So I'm using the platinum marker to guide this. We can go again up to 18 atmospheres. Yep, keep going.
18.
Yeah, excellent.
And how long a segment have you done with this? You know, I know the trial had a certain
So, so
length.
yeah, so so in this trial, which is Life BTK, the maximum number of scaffolds that were implanted as part of the protocol was 3. And I think you're starting to see anecdotal experience with putting in more than 3. I don't think that that's necessarily evidence-based right now, and I think objectively it's probably a little bit of cost prohibitive. And so if I'm knowing well ahead of time that I'm putting in more than 3 scaffolds, I'm probably going to use a permanent metal DES. We can take it down now. So again, if you look at the fluoroscopic image down on the bottom, you see that there's probably 2 millimeters, 3 millimeters of overlap between those 2 platinum markers. And I think for me, like, that makes me happy. I'm pretty satisfied with that.
And then how are you
So I
following when
think,
you're following these patients
go
in
ahead.
the office? What's your algorithm as far as like either duplex ultrasound or a toe pressures, or what's your kind of or
So
what are you
obviously
using?
for somebody with rest pain, as long as the rest pain's gone, like, I feel that's a home run, So that's probably first and foremost what I would answer for you. But we do duplex without question. We want to make sure that there's no focal stenosis that we're going to see on duplex. Um, Almost all these patients, and I expect this patient afterwards, and I can put it on the back edits. We'll have a palpable DP pulse, which you can follow up very inexpensively in the office, which is a great option. But it's really symptoms. Um, See, that segment looks so much better now. All right. So that mid segment that had that collapsed area, that's well treated. All right. Um, so we're at time at the hour, Joji. So I know you have obligations, and I appreciate you joining us here. I think we're able to demonstrate a lot, which is how valuable IVUS is in terms of sizing not only your vessel prep platform, but your perhaps your IVL strategy, and then using it to measure the size of these scaffolds. I think we have a really nice result here for this patient. We may very well off camera, optimize the tibial peroneal trunks. I do think that's going to lead to this patient having a more durable result afterwards. But I personally want to thank you for all your help and guidance for the last hour over this case. Do you have any closing comments or questions before I let you go and wrap up?
No, I think it's a great case and showcasing the importance of IVUS, modifying technology, and a new kind of drug eluting absorbable scaffolds. Well done, and very important for trainees to kind of learn this in your residency and fellowships. All right, thanks so much. Appreciate the time.
Thank you so much. I just want to, again, on closing, I want to thank all of our staff. I want to thank my star fellow, Raj Rao, for, again, keeping me on the straight and narrow and keeping me out of trouble. I want to thank all of our staff, our nurses, our techs, our support for not only the IVL platform, but for intravascular ultrasound, our anesthesia colleagues. And last but not least, I want to thank BroadMed AV, who's been our incredible AV partners on this journey and has helped bring all this great educational content to all of you. So I hope this was enjoyable. Thank you very much, and we'll see you all next month.